presentation on innovations in systems of percutaneous thrombectomy. Dr. Keshav Sadhwani, Dr. Ravi Bansal, Dr. Saurabh Pokhriyal, Dr. Ritesh Sharma. Please proceed to the dais as chairpersons.
Good morning, everyone. The next session is on innovations in systems of percutaneous thrombectomy. Can you please call the speaker?
Sorry, Dr. Gaurav Sagar. Dr. Sampath Kumar, please join us on the dais. I'm sorry, some of the other chairpersons have not arrived yet. And Dr. Shenoy will continue with his presentation. You could have done it all together.
Dr. Shenoy is the speaker.
Please begin, sir. You were saying something. I'm sorry to interrupt.
I invite Professor Shenoy again to talk to us about the innovations in systems of percutaneous thrombectomy.
Thank you. I'll be talking about innovations in systems of percutaneous thrombectomy. As you see here, there are a lot of devices out there in the market to do percutaneous thrombectomy. And I'm sure you all know that if there is a problem and there are 10 solutions or 20 solutions being explained for the problem, it's very clear that none of them are good enough, right? So there are new products coming up also. So instead of trying to dissect out each one of them and tell what is good, what is bad about it, I would rather go over what is the problem and what is the solution being looked at and what is the advantage of having certain solutions. Now, if I give you the background like that, probably when you look at a product which comes to you or when you try to buy a product for your use, you will be able to make an informed decision on what fits your setup. So when we talk about thrombectomy, if you go back to Doki clearly says that any access that has been functional for some time needs to be thrombectomized. You shouldn't be giving it up without doing anything to the access. It's very certain that you have to do that. There's no doubt about it. But the question is what method we should use to thrombectomize it, whether we should do it surgically or percutaneously. Now, to understand that, we need to kind of know a little bit about thrombosis. Thrombosis always happens secondary to stasis of the blood. And stasis of the blood in an access always happens to secondary to stenosis somewhere in the circuit, which is the most common cause for thrombosis. Now, every thrombus has what is known as a platelet plug on one side, usually on the side where on the arterial anastomotic side, in the arteriovenous anastomotic side, and then there is a red clot which goes through the rest of the access site. The tail of the clot usually ends at a point beyond which the vessel will be still patent, and usually that tends to be the point where there is a stenosis. So the difference between these two is important because the platelet plug is very solid. It cannot be dissolved. It generally cannot be lysed, and every time you do a thrombectomy, you will be able to clean up this part of it, but platelet plug tends to get back and get embolized in the body into the lungs. And this happens with all the time when we do the declots. So if the stenosis is at the inflow, your flow in the access becomes less. When the flow becomes less, you tend to have a clot, and you tend to have not a dilated vessel, but you tend to have a normal looking vessel, and the clot tends to be less complex. In other words, there will be more the red clot and the white clot, whereas when the stenosis is distal, proximal towards the heart, and you have obstruction leading to pseudoaneurysm formation or aneurysmal dilation of the axis, you tend to have slowing of the flow, you tend to have chronic thrombus developing on the wall, and when it's thrombosed, you will have a mixed clot with chronic thrombus and acute thrombus in that. Now, any method of percutaneous thrombectomy cannot handle the chronic thrombus very well. It can handle the acute thrombus. So this is something to remember because it becomes important while making a decision which method to use, how to declot a given axis which is thrombosed. Now, advantage of the open technique is that open technique allows you to do a complete thrombectomy in the setup of chronic thrombus without having to worry about embolization. So there's a distinct advantage there when you're doing open thrombectomy. Having said that, how to evaluate a given axis? When the patients come to us, you can have thrombus in any kind of an axis right there. For evaluation, we do a good clinical exam. Then we'll try and look at how well the axis was working, what is the overlying skin condition, is there any suspicion of infection. Then we can do an ultrasound which can differentiate between chronic thrombus and acute thrombus. Ultrasound can show you if there is a burden of chronic clot, and one should always assess the burden of chronic thrombus in a given thrombosed axis. If the thrombosis is recent, mostly acute clot, low clot burden, good skin condition, no suspicion of infection, and if there is expertise available, percutaneous thrombectomy has to be done in these patients. There are certain contraindications for percutaneous thrombectomy. Mainly, if a patient has got right to left shunt, you don't want to embolize that plug and have a paradoxical embolism. Or in a patient with pulmonary hypertension, when they have poor pulmonary reserve, even that small thrombus embolizing in the lung can tilt the balance. So those are some absolute contraindication. Then there are some relative contraindication for percutaneous thrombectomy. The principle of percutaneous thrombectomy is very simple. We need to get into the vessel, and there are different methods by which we can get into the vessel. Once you get in, you get a scout film to make sure your outflow is okay, and then go ahead and then clean up the red clot, and then go tackle the white clot. Most of the time, the white clot is tackled with a Fogarty embolectomy, and it gets embolized, reestablish the flow. If there's a stenosis, dilate the stenosis in that situation. Most of the time, this is a great advantage of percutaneous thrombectomy because percutaneous thrombectomy allows you to image the entire circuit, and usually thrombosis happens because of the stenosis in the circuit, and we can manage the stenosis during the percutaneous thrombectomy because we can see it well. Where do devices come in? Devices come in mainly to manage the clot. How are we going to lyse that clot when you get into the vessel percutaneously, and how are you going to remove that clot when you get into the vessel percutaneously? That's where most of the devices come in. As I said, cleaning the platelet plug, most of them are using Fogarty catheter to clean the plug, but there are a few devices which consider maceration of the plug too. Most common procedures used for thrombectomy are thromboaspiration, lyse and wait technique, lyse and go technique, or mechanical devices, or pharmacomechanical devices, combination of these two, and angioplasty. Thromboaspiration was described quite some time ago. Luke wrote a nice article early in 2000, and this is very simple. You have catheters. You agitate the clot with the catheter by simply rotating the catheter inside. Once you're in there, use a large bore syringe and aspirate it as you are lysing the clot, and this gives you pretty good results. Now, same thing as now mechanized. You are available what is known as a catheter, that is continuous aspiration mechanical thrombectomy devices. These catheters are very good. They got very thin wall. They've got large bore lumen. And recently there was an article which was published which showed pretty much good results by catheter aspiration mechanical thrombectomy. This is purely mechanical thrombectomy, no medications used in the situation. The most common mechanical thrombectomy device which is used out there is called an aeroteratola device. This is actually a titanium basket. It rotates very fast at around 3000 RPM, and it comes in different lengths. You can put it through a 5 or 7 French sheath, and it goes there. When the basket rotates, it lyses the clot, and you can aspirate the clot out. Here is this is a picture given to me by, I think, Dr. Dhiraj Rajan, and you have a clot in the graft, mechanical device going in there, macerating the clot, blood flow reestablished. There's the stenosis which will be embolized. Now we can use the same thing for fistula thrombectomy, especially in fistulae which don't have too much clot burden. Now, one of the things to realize in the fistula is that fistula clots tend to be more adherent to the wall as opposed to a graft clot. So you might have to really put some digital pressure from outside while you're pulling the brush out or macerating with the brush that allows you to lyse the clot a bit more better as opposed to a graft clot. Another mechanical device which is out there, which is called a cleaner brush. This also is used often. Now, if you ask me which one to use, it is user preference most of the time. There is nothing specific. I got 8 interventionalists in our place who do thrombectomy, and if you go ask them, same person uses sometimes one, sometimes something else. I know it's just flavor of the day. There's not much of a difference in that. Each one has got subtle advantages, and again, depends upon the user what is better. But bottom line is this is a mechanical thrombectomy. Now, both these devices have side ports, and actually you can convert it into pharmacomechanical by injecting some lytic agent up front and then using this to lyse the clot better. So these are similar devices. This actually this works like a guide wire. You don't have to ride it over the guide wire. It acts like a guide wire, and the configuration of this rotates faster than the other one. I think this is around 4,000 RPM as opposed to 3,000 RPM. So it's a subtle difference. Then there is another device, angiojet, again for a pharmacomechanical thrombectomy, where you can inject. It's got an injection port from the side. You can inject medications. And earlier you could use only saline. Now you can use lytic agents. Basically here, it creates a vortex which sucks the lysed clot out. So that's a device, but you need a console for it. Some places people have this console already because cardiologists bought it, and when you have the console, it becomes easy to use the same console to do the thrombectomy for for vascular access. Lyse and wait technique. Earlier, the first time when it was described, it was simple. You apply digital pressure on both sides and put lytic agent inside. Lytic agent lyses the clot. You let the patient sit outside in the clinic for about 30-40 minutes, take him to the interventional suite, and then aspirate the clot out. That was lyse thing. The same one was converted to lyse and go. You apply, basically, you don't wait for 40 minutes, you wait for a few minutes and go back and try to do it. You don't have much time to waste. That's when lyse and go came in. Again, these were early attempts. Nowadays, we have gadgets available to do the same thing. We can, instead of injecting digitally, we got gadgets through which you can inject with high pressure. You can have pulse spray all along the clot. Then there are combination devices. Instead of trying to digitally occlude it, you have a single device which has got 3 ports. One allows the balloon distally, balloon proximally, so there is no embolization. Second port allows you to put the lytic agent inside. The third port allows you to aspirate. These are all devices which have helped us or have been devised to help us do the same thing which we did little bit imprecisely by doing it with manually. But now we can use the devices. But again, one has to estimate the cost of the device whenever we think of using a device. What about the outcome? If you look at the outcome, technical success for most of these devices have been pretty good. But when you go to 3 months, it's been better than what Doki wanted. Doki wanted about, for percutaneous thrombectomy, at least 40% 3 months patency. They're all pretty much there. But then there's no much of a long-term advantage one way or other. But obviously, this is very advantageous for the patient because you don't have to go to the OR, wait for the OR time. You can have it percutaneously done. There are a few series which have been completed, which are out there. And again, if you look at those series, using a device and doing a simple thromboaspiration has done pretty well. So there is no real reason that there needs to be a device to do it. What is new out there? I want to just show you a couple of things. If you take that address and check it out. There's a very nice demonstration of this new device which is out there. Again, it's not FDA approved for thrombectomy. It's got a nice basket which goes in, captures the clot. It can pull out the whole clot out. That's why I thought probably something which is going to be tried in the future. We also had recently an article about using ultrasound enhancement. It's been shown that ultrasonic waves at 2 megahertz can, along with TPA, can enhance the lysis. And there was one article using that for vascular access. But again, these things are not available at this point of time. They are all in the experimental state. So in summary, percutaneous thrombectomy is an effective with primary patency rates at 3 months that exceed DOKI requirements of 40%. Long-term results of percutaneous thrombectomy continue to remain poor. There is a need to develop devices that can successfully identify and adequately manage the chronic thrombi. That seems to be the major problem when we go with percutaneous thrombectomy. And we don't have good ways of managing it at this point of time. Now, one should remember that if you are trying a percutaneous thrombectomy, the key for success is complete removal of the thrombus. More complete we do it, better is the outcome in these patients. Thank you. Any questions?
How long